the girl, which one I should make co-host?
So demo gene and ops department.
Demo, right? Okay, optional regula. Allow to record local files there. Make co-host. Okay.
Make co-host. Sir.
Okay, co-host kara. Host disabled participant screen sharing. I'm the host now, so where disabled the Mava?
No, sir. Wait, listen.
Hey, Mava, can you make it? මට දැන් මොකද වෙලා තියෙන්නේ? Now I can't. Host disabled participant screen sharing කියලා තියෙනවා.
Please wait, sir.
All right, okay. Okay, right. Can you all hear? Can somebody talk, please?
Yes, sir.
Only 58 of you are there.
Others are joining in, sir.
Others are joining?
Yes, sir.
Okay, okay. Can I wait for them or shall I start and continue? I'll continue, no? So you're going to record and show it to them, no? Okay.
Yes.
This is, yeah, we are going to discuss about antepartum hemorrhage, okay? Antepartum hemorrhage, yes. Before antepartum hemorrhage, before talking about antepartum hemorrhage, you should know the background of this obstetric hemorrhage. Obstetric hemorrhage kyanne, any woman, you know, at the time of pregnant woman having some form of bleeding. Either this can be threat, you know, it can occur in the early pregnancy bleeding. This can occur in the, you know, it can be a an incomplete miscarriage, or that can be a miscarriage, sometimes septic abortion, septic miscarriage, ectopic pregnancies, and again in the second half maybe in the, you know, antepartum hemorrhage, whether, you know, due to either placental abruption or placenta previa. Some after delivery again, you know, postpartum hemorrhage. It can be primary, secondary. Sometimes, you know, shock obstetric, you know, it's after delivery, some hematomas like broad ligament hematoma, uterine ruptures. All these are categorized as obstetric hemorrhage. So most common cause of maternal death worldwide, and accounts for 30% of the maternal deaths again. So most often, interestingly or pathetically, ironically, the you know, deaths due to hemorrhage can often be more than, you know, 70% can be avoided. Okay, so the reason why it happens is we give, you know, we provide of care provision is given too little too late. Okay, so that is the common reason. Too little too late. Too little things we give too late. Okay, so blood loss is often underestimated. Sometimes in pregnancy, you know, pregnancy compensation occurs. So when a patient loses blood, initially she will until she loses about 2 liters or 3 liters or more than 2 liters, until she loses about 35% of the blood volume, she will not show any significant signs of, you know, hypovolemia. Initially, when she loses blood, she will show kind of activation of renin-angiotensin system will activate sympathetic discharge. So she will have high pulse rate, will be high. Blood pressure will be normotensive or slightly it will be low. Urine output initially will remain normal and slowly it will drop. Respiratory rate will go up. And she will be sweaty and cold clammy peripheries will be there. All this will appear, and finally only the blood pressure will drop. So never ever think, okay, don't take blood pressure as a measure to evaluate or blood loss in a patient, especially in an obstetric patient. This can kill the woman. Okay. So the common topic is obstetric hemorrhage. This can be divided into various bleedings, but generally two main things are there. Antepartum hemorrhage, a pregnant woman, or before or after 24 weeks, if she bleeds, that is called antepartum hemorrhage. After 24 weeks, before 24 weeks, we don't call it antepartum hemorrhage. We call it using different terms. Antepartum hemorrhage is after 24 hours until delivery. Postpartum hemorrhage is delivery after childbirth. So there is a kind of it's this well-known dictum: antepartum hemorrhage weakens the mother. Antepartum hemorrhage is they start to bleed repeatedly, they may bleed, and that weakens the mother, and mother will be very weak at around the time of delivery, and subsequently she will end up in a postpartum hemorrhage, and that will kill the mother. So if a woman comes with antepartum hemorrhage, you should anticipate postpartum hemorrhage as well. Okay, so hemorrhage, when it occurs either in pregnancy, antepartum, or postpartum, they may have all these features: pale, confused, increased heart rate. Reduced blood pressure will be a late sign. Don't depend on the blood pressure to judge or evaluate bleeding. Fetal heart abnormalities can be there, sometimes may not be there. Urine output, these are the features. Bleeding, sometimes antepartum hemorrhage, bleeding can be visible, sometimes it can be not revealed, or kind of hidden bleeding. So when the signs of bleeding are there, when those symptoms, pale, confused, increased heart rate, reduced, then think bleeding has happened, significant bleeding has happened. You have to act very fast. When you go to labor room, or when you see a patient, if you see with these signs, somewhere, or she has bled a lot, her blood loss is almost close to 2 liters, so you have to act very fast, because there is something called golden hour. Golden hour is these bleeders, you need to, when the bleeding episode starts, you need to treat within 1 hour. Otherwise, if you haven't treated them properly in the second hour, there is a high chance of maternal mortality and morbidity. So there is a chance that that will lead to a death. So when the signs are there, that can be very significant, so you have to act very fast. So this is the background information. Keeping this background information, will go through some scenarios. Antepartum hemorrhage is defined as bleeding from or genital tract occurring from 24 weeks onwards prior to birth of the baby. Okay, so that is called antepartum hemorrhage. Antepartum hemorrhage, not postpartum. So I'll tell you a scenario. So a woman, can somebody read? So I will nominate somebody has to read this out. Come on. So you want me to tell who that person would be, or can somebody, quick. You have to quickly finish it. Come on.
So, a 35-year-old P4 C2 presenting with painless vaginal bleeding at 22 weeks of gestation, previous 2 vaginal deliveries. She says she fully soaked 2 pads at home. What are the differential diagnoses, sir?
Sorry, make a 32 weeks. Sorry. Yeah, sorry. Yeah, it is 22 name 32. Sorry, 32 weeks. Okay, 22 one. It can't be antepartum hemorrhage. No. So a 35-year-old woman, multiparous. She has had 2 normal deliveries. 34 weeker, 32 weeker delivery, coming with bleeding, painless vaginal bleeding. Okay, what is the main diagnosis? What would be the main, what is the common, like, what is the problem that you anticipate in this one? Fully soaked 2 pads. When a woman comes with bleeding, what are the differential diagnoses? Yeah. Kiande. Yeah.
Placenta previa,
Good. Yes.
also placental abruption.
Placental abruption. Yes. So in this case, what is the diagnosis? Why what is the diagnosis?
This is painless vaginal bleeding, so placenta previa.
Placenta previa. Yes, good. So it can be placenta previa. Sometimes it can be Vasa previa if there is a, the blood vessel that is crossing the internal os could have, ruptured. So sometimes unexplained antepartum hemorrhage. Having excluded all this, it can be a polyp, or sometimes it can be an excessive show, preterm labor. Okay. So, right. Okay. Her heart rate is 110 beats per minute. She has, heart rate anxious, maybe blood, or maybe the blood loss. Blood pressure is okay, 110/70. Saturation is 96 on air. Respiratory rate is slightly elevated. How would you manage in this woman in this situation? Okay, what are the next steps when the woman comes to the ward? Okay. Fernando Pulle. No, they okay.
Yes, sir.
Yeah. What would you do in this situation?
Initially, sir, since she's been bleeding, we need to resuscitate her using the ABC approach. And then we need to identify what the problem is and see the severity of bleeding.
What else? Hello? Yeah, go ahead. Initial steps, yeah.
In the
Initial
ABC
steps,
approach.
ABC approach. You have to check ABC approach and circulation. You have to secure 2 wide bore cannulae or maybe a 1 bore cannulae and take bloods. And she may need a fluid resuscitation. Okay, rapid resuscitation with maybe some crystalloids initially. Send off cross-matching blood. Okay. So manager, and we normally conservatively manage, usually 32 weeks. If the bleeding settles, you keep her in the ward, give certain things like dexamethasone, anticipating a premature delivery. If the blood group is negative, give Rogam, and maybe anticipating that delivery, you may have to refer her to a neonatologist, make sure that the incubators are available, and then talk to the woman, do a scan later, and scan, like sometimes you have to do a transvaginal scan to see the grade of the placenta and placenta previa, major or minor degree, and plan. So we usually try to adopt a conservative or expectant management rather than going for immediate delivery. So sometimes if the bleeding settles, if it is a minor, if the minor posterior, like low-lying placenta, no much, it's not a major degree, in that case we will send her home, expecting her to come with labor pain, or sometimes if okay. So what would you do? So how would you advise her? Bleeding has settled, it's a placenta previa, then what would you tell her? Come on. So okay, so you have to tell her, okay, placenta previa, anytime she can bleed, so she should remain somewhere near the hospital. You can't send her like to Avisavella or some Badul. Some patients are from far away, so Puttalam, so you can't send them. If they are nearby, and if they are, if the knowledge is good, if there is a support to come, if there is a means to come, then you can discharge her. You can discharge her and send her home and bring her back on, if the bleed settles. So bring her back in 1 or 2 weeks time to evaluate. Sometimes placenta may go up. So that is the, if the placenta migrates, if the placenta goes up, then you can, continue the pregnancy until at least 36 weeks. Okay, so placenta previa, and again 25-year-old primary presenting at 34 weeks gestation with vaginal bleeding and low abdominal pain. So so low abdominal pain, yes, what would you do? What is your initial management? Why, what would you do again? Come on, කවුරු කෙනෙක් කියන්න? කවුද? Harshana, MAK, කියන්න බලන්න. So tell me. So abdominal pain and bleeding, PV bleeding.
Initially, I should resuscitate patient with ABC approach. If PV bleeding is high, the blood pressure and pulse rate and can be vary, and airway and as ABC approach, I go to the initial management and do the full blood count and see the HB level. And then I should do transvaginal ultrasound and exclude the placenta previa.
So placenta previa, do you exclude by transvaginal scan? I don't think. Normally you don't have to.
Clinically we can do.
It's a clinical diagnosis. Okay.
Yeah.
So you diagnose clinically. Okay.
This is most likely placental abruption.
Yes.
And there may be conceived bleeding there. So scan should done. And if the if maternal and fetal well-being is good, we can conservatively manage. Otherwise, we have to immediately delivery patient by if maternal condition is good, we can deliver by normal vaginal delivery. Otherwise, we have to go cesarean section, and we have to consider the DIC here. But we should
very good.
We should do PTINR test and see the counts also.
Okay. Yeah. So you are right. So so initial management, your airway, breathing, circulation, and then cannulae, bloods, including thromboprophylaxis. Sometimes they come with back pain, abdo pain. Sometimes bleeding can be there, or you may not see any bleeding. Okay, abdomen will be tender and irritable uterus. In that case, you have to do the needful. So you answered some of the questions I'm going to ask. Okay, after initial resuscitation, you have done airway, breathing, circulation, put a cannula, sent off the blood. You inform your senior registrar or registrar. He raises concerns, asks you whether this can be an abruption. How would you justify it? Okay, you told that, no? So there is pain, abdomen is tender, irritable abdomen. She is continuously complaining of, abdominal pain. There is a little bit of bleeding. And CTG, in the CTG, you may see evidence of fetal distress. Okay, so this can be, these things will exclude. Okay, then you have to think, okay, am I going to deliver immediately based on the level of certain things? One is maternal compromise, fetal compromise, available resources, and the maturity. And mostly you have to take maternal condition as a priority. If you think, okay, this is going to complicate the matter, then you will have to do a cesarean section and deliver. If you think, okay, my mother is stable, bleeding is not significant, baby is also stable, then you can consider either induction or normal delivery. If there is no imminent, delivery, imminent evidence of normal delivery, then you will have to go for C-section. Okay. So antepartum hemorrhage, again, we know we have discussed abruption, placenta previa, vasa previa, unexplained. There is a group called unexplained. So we'll talk about abruption. Yes, premature separation of normally situated placenta, not lower. You don't call it if it is located in the lower side. So normally situated locate occur in 1 in 200, and bleeding can be revealed. Sometimes it can be concealed, sometimes mixed, revealed and little bit concealed also. Sometimes mild bleeding, but you think it is a mild abruption, but you see a big clot. Okay, so doing a scan will not show anything. It's not a sensitive way. You have to just clinically diagnose. Abruption is a clinical diagnosis. Tender, tensed, enlarged uterus, degree of shock does not always show any proportionately, show any kind of blood loss. So sometimes there can be a small blood loss, but patient can be in shock because this bleeding is concealed. Fetal distress, or even when the patient comes, it can be an IUD. Okay, they can have acute renal failure, clotting DIC, and you also should look for postpartum hemorrhage. Okay, this slide shows the differences. We all have discussed. I'll leave this slide for you. So differences of placenta previa as well as placental abruption. Okay, vaginal examination, you should avoid it unless if it is a abruption, then you can gently examine. If it is a placental previa, you should always avoid, but those days we were avoiding, but anyway, if it is an antepartum hemorrhage, don't talk about the vaginal examination. Tell that you would do a speculum examination, okay, to just see whether there is active bleeding. Okay, so color of the blood and all, those are not sensitive things. Painless bleeding, placenta previa, bleeding is always revealed. Okay, so and also provoked. They will come and say, I did this, I played, I had sex, and blah blah blah. If it is an abruption, yes, again, after a fall, after a blow, after a road traffic accident, yes, those can be there. Okay, so if it is associated with pain, always suspect an abruption. Abruption also management, airway, breathing, circulation, initial resuscitation, make a diagnosis, delivery is the ultimate management, and then look for complications and treat. Okay, what are the complications of abruption? Can somebody tell? What are the complications of abruption? Yes, කවුද කෙනෙක් pick කරන්නද මම? හර්ෂණී කියලා කෙනෙක් ඉන්නවද? 0456 හර්ෂණී. What are the complications of abruption? හර්ෂණී නැද්ද? Right, okay. මම අල්ලන්න තව කෙනෙක් හර්ෂණී WT ගිම්හානි WAY.
So there can be complications like shock.
Very good.
And like Kokila mentioned, there can be a coagulopathy. And also there can be complications for the baby like hypoxia, premature stillbirth.
Very good.
Premature
Maternal
birth and
complications, yeah, maternal complications, fetal complication. Where do you do Kleihauer test?
it's in rhesus negative
Yeah,
mothers.
even rhesus negative, yeah. Kleihauer, rhesus negative, not current see to see whether there is a significant fetal-maternal hemorrhage. You can diagnose. You can not diagnosis that will support abruption. But if it is rhesus negative, also you can do abruption. You can always do Kleihauer test to see whether there is any evidence of fetal-maternal hemorrhage. Okay, so. And also there is something called DIC, acute renal failure, Cuveliers uterus. Have you heard about it? Cuveliers uterus. Can somebody tell what is Cuveliers uterus? No one knows about Cuveliers uterus?
So the blood percolates into the myometrium and uterus becomes hard and contracted.
Yeah, blood squeezes into the myometrium. And the uterus will appear like bluish structure, and that become atonic, and the atonic pph will, you should anticipate an atonic pph. So you should know this basis of all this, complications also. Harida, I can't teach everything in this, you have had this somewhere. So management depends on various things: maternal condition, fetal condition. Especially if it is a live baby, you should immediately deliver. If there is no imminent delivery, do a C-section. Dead baby, if the mother is okay, you can continue the pregnancy and deliver. But if the mother is not stable, deliver immediately. Okay. So complications. So these are the complications of antepartum hemorrhage. It can be anemia, maternal shock, RIF, acute kidney injury, coagulopathy, consumptive coagulopathy, DIC, postpartum hemorrhage, prolonged hospital stay, psychological, fetal, as I said, fetal hypoxia, iatrogenic prematurity, fetal death, all those things can happen. Okay, maternal age parity. These are the risk factors of abruption: age parity, smoking, cocaine, multiple gestation, chronic hypertension. These are sometimes most of the patients don't have any risk factors. Okay, even pre-rupture of membrane, rupture of membrane also can lead to. These are some of the, again, MCQs in the list. Okay, this is coeliar uterus, so it becomes bluish in color. Okay, what are the risk factors of placenta previa? Again, age, IVF pregnancy, multiparity, subfertility, these are some risk factors. Okay, advanced age, multiple pregnancy, previous C-section, fibroids, all these are complete risk factors. So the placenta previa can be graded type 1, 2, 3, 4. This is how if it is just away from the lower internal os, and if it is located in the lower segment only, then you call it type 1. Type 1 and type 2 are called minor degree. So if it is just at the internal os level, it's marginal or type 2. If it is just covering partially, that is type 3. If it is completely covering central, it's called major degree. So minor degree and major degree placenta previa are there. There is something called Vasa previa. So if the membrane, usually membranes are entering the placenta through a kind of an area in which is covered by amnion. So here fetal blood vessels are directly exposed, and when you do ARM, or if it breaks spontaneously, commonly ARM, you break the blood vessel and kill the woman, kill the baby, because baby's heartbeat will drop rapidly. Okay, so that is called Vasa previa. Whatever the cause, all cases of, again, these are the management: airway, breathing, circulation, IV cannulae, bloods, and beware of catheterize and empty the bladder, beware of potential disorders. Right, finally, you should always think, okay, is this woman an Rh negative woman? Should she need steroids? Involvement of the neonatal team, you have to always refer the patient to a neonatologist to get some idea, or sometimes you may have to transfer out as an OPD patient to another unit, that is called in utero transfer. Anesthetist, hematologist should be involved. Sometimes DIC, sometimes preeclampsia, all these things can coexist. Okay, Meo's chart, when you are monitoring, you can use maternal modified early warning chart use කරන්න පුළුවන්. And also, if abruption occurs before 34 weeks, you should always think, okay, this could be a thrombophilic condition. You should refer them to thrombophilic hematologist to do exclude thrombophilic conditions. And also placenta will be sent for placental study. That also will give some information. Okay, any questions?
So what are the induction methods usually used in abruption?
It's not major abruption. Okay, when you think, okay, minor abruption, sometimes antepartum hemorrhage. That is not happening in Sri Lanka. We don't use it. But when a patient comes in England, when a patient comes with unexplained antepartum hemorrhage, we used to put prostaglandin, either gel or pessaries. If there is any problem, do C-section. Otherwise, anyway, you are not going to keep the woman when they come with mild abruption.
Thank you, sir.
Okay. Any
So, what
question?
is the cutoff period for the thrombophilic screening, sir?
After 6 weeks, no? Yeah. Okay. What else? Okay, these are the important things, and always, debrief. You have to debrief the patient and family. Okay, debrief Karandone and document it properly. Okay, that's all. If you have any questions, you can ask me, or else contact karana puluwa. Okay. Okay then. Okay. Bye.